Clock. Good morning, everybody. I'm going to start over again for recording purposes. So welcome to our final day of our 2.5-day workshop. And for those of you who have stuck with us, thank you for your interest and support, and we value that so much. We're going to finish at noontime today in North Carolina, and but before we do that, what I would like to do is remind you of this wonderful phrase, in Aymara, the indigenous people of Bolivia, that it would always be good for us to communicate among ourselves, which is what we've tried to do in this workshop. And it's very difficult in our hurried world that we live in to take time to step back and reflect on some important ideas and issues. And I hope that this workshop is giving you a chance to do that in a lot of different ways. So I thought I'd start out with a quiz. So I'd like to know who can recite the definition of epidemiological priorities. Nat Robinson gave it a try on, was it on Monday, Nat? And he got it 99% right, but not 100% right. So who would like to give that a try? And somebody joining in online would be good to hear from. So who's brave enough to give this a try? Just unmute yourself and let us hear from you. And don't be bashful. If you get it wrong, you'll just get 3 lashes with a wet noodle, but nothing else. It's a very important component of what CBIO is all about, so I'd like to keep reminding people of what it is. Would anybody else in the room like to give it a try besides Nat? I'm going to call on somebody if somebody doesn't volunteer. So. No takers? Okay, Andrew, I'm calling on you. Come up here.
Readily, what are the epidemiological priorities? Most severe, readily treatable and preventable diseases in the community. Something like that.
Okay, I'll give you a C-. Anybody else want to give it a try now that you've seen Andrew give his best? No other takers? Nobody online?
Okay, somebody put in the chat.
Okay.
The most frequent, serious, readily preventable conditions in a community or treatable.
Okay, say that again.
The most frequent, serious, readily preventable conditions in a community or treatable.
Okay, I think that's an A. I say it slightly differently, but it's almost, I think all the ideas are there. The most frequent, serious, readily preventable or treatable conditions, not diseases, but conditions, because there are other causes of ill health that are not diseases. So conditions, the most frequent, serious, readily preventable, or treatable conditions within that population of people of interest. So congratulations. Who was that put that in?
And May.
Oh, my wife. And May Potoshink, our backroom manager. Okay, thank you. Okay, so here's the next question. Who can explain what the three-legged stool of global public health practice is? And Mirlyn is not allowed to answer, my wife, and May, you're not allowed to answer either. So we want to hear from somebody else. I'm going to call on somebody if somebody doesn't volunteer. This is the prerogative of a teacher, you know, we can do that. Okay, let's see. Who can I call on? I know. Okay. Stanley Blanco, you're on the hot seat now. Stanley Blanco is one of our Bolivian colleagues who's had an amazing career in public health and has been connected to our work, but also with many other programs in not only in Bolivia, but throughout South America. So, oh, wait a minute. So Stanley has typed in policy, practice, and research. So Stanley, I hate to tell you, but you failed. Who else wants to give it a try? Was that Alma? No.
¿Alma quiere responder?
Do I get to participate or am I out too? Well, let's wait a minute, Nat. So.
You hear Alma?
Okay, Alma Dominguez says that she'd like to give it a try. So Alma, come on up here where everybody can see you and hear you well.
One of the challenges Mario is saying is that the PowerPoints haven't been in Spanish.
Buenos días. Yo entendí de que se trataba de los socios y los servicios de salud que pueden apoyar, que si uno no está funcionando bien, pues va a debilitar a los demás programas que existen dentro de la metodología.
Se puede repetir otra vez. And by the way, if you're an English speaker, you have to check into the English channel, right?
Right.
Not everybody knew that yesterday. In fact, my wife didn't know it. So if you want to understand what Alma says and you're an English speaker, you have to sign into the English channel, English speaking channel. So say it again, Alma.
Yo entendí de que se refiere pues a los servicios o a los socios que participan en la para el desarrollo de la metodología, que si uno no está funcionando bien, pues obviamente va a debilitar la mesa, ¿verdad? Porque no se sostiene bien.
Okay. Okay, so that's a beginning.
She also said, communities and she said services.
Yeah. So Alma was talking about services is one of the three legs of the stool of global health, public health practice, communities, and then services. So that's a partial answer, and I guess I'll give you maybe a C on that, Alma. So who can improve on that answer?
There's somebody in the chat.
Okay, we have somebody who responded in the chat who said, okay, great. Vertical top-down disease-oriented public health, services-oriented public health, and community-oriented public health. Bingo, A+. Okay, great. Okay, that's wonderful. Now, what is the goal of vertical disease-oriented public health practice? Somebody can unmute themselves or type it in the chat, that'll be fine. What is the goal of top-down, vertically oriented, disease-oriented public health? What's the goal of that? I'm going to call on somebody. Okay, Barbara, you're in the hot seat now, so come up here and tell us what the goal of top-down, disease-oriented, vertically oriented programs, what is the goal of that in terms of public health practice?
The goal of these top-down vertical programs, my guess would be, is to address a specific disease and prevent a specific disease. So treat and prevent a specific disease, which you mentioned top-down, so I'm assuming has been decided prior to implementation in the community.
Okay, very good. I'll give you an A on that. So we're talking about public health practice. So by definition, we're talking about a defined community of people. That's what public health is, addressing a population as opposed to an individual. So the goal of disease-oriented public health, one of the three legs, the goal is to control or reduce the effects of that disease or that condition within a defined population of people. Okay, so what's the goal of services-oriented public health? No takers? I'm going to call on somebody. Andrew, come over here so I can see the list of everybody who signed in. Okay, I'm going to call on Michael Tetti. You seem like you were capturing a lot of this stuff yesterday. So, Michael, what is the goal of services-oriented public health? You can
Good morning, Dr. Perry. I was hoping you won't call on me, but I'll give it a shot. I think it's the goal is it curative medicine to treat people of I honestly not sure.
Okay. Anybody else want to give it a try? The goal of services-oriented public health, the second leg of the virtuous stool of global public health practice, the goal of services-oriented public health is to get basic and essential services to people who need them, not just curative care. And it also has the outreach component. We're talking about public health practice. So it's getting basic and essential services out to people who need them. All right? So now we come to the final leg of the virtuous three-legged stool of global public health, which is community-oriented public health, something that most people have never heard of. So here's the most important question of the morning. So what's the goal of community-oriented public health, the public health practice, the third leg of the stool? All right, I'm fixing to call on somebody. Okay, Brenda Suleiman said, focusing on the whole community and what they see is the most important. That's a good try, but it's not correct. Of course, it's a part of it, but it's not the whole thing. Okay, so Kevin Cayando, come up here and give us your attempt to answer what the goal of community-oriented public health is. Taking the prerogative of the teacher to call on the student.
Okay, thank you, Henry. In my opinion, the goal of community health, public health practice is to
community-oriented
community-oriented public health practice is to get the community to identify their own community health priorities and merge epidemiological priorities and community health priorities as an intervention.
Okay, I'll give you a B- on that. That was a good try. Anybody else want to give it a try? Stanley. Okay, Stanley Blanco has signed in. He's trying to redeem himself. He says the goal of community-oriented public health is focusing on the health needs and priorities of entire communities rather than just individuals. Stanley, I'll give you a B- on that. That was a good try, but didn't quite hit the key points. Adam Paul, he says the goal of community-oriented public health is that health workers must do, let's see, what is that? Health workers must doing good relationship with community leaders. So I'll give a C to you on that, Adam. You missed some of the key ideas. Anybody else want to give it a try? So the goal of community-oriented public health, which I consider CBIO to be a part of, the goal of community-oriented public health is to work with communities to help them improve their health. So I give credit to John Wine for this. He came up with this, and I think of it every day, and I think it's an incredibly useful and valuable orientation to think about what it is we're doing and why. And of course, these three legs of practice, as I said on the first day, they're mutually reinforcing. They're not totally separate, and you can think of a lot of different ways in which certain practices and programs are reflective of more than one of the legs. But still, I think it's a nice conceptual framework to keep in mind. So I wanted to help you try to remember all this. So don't feel embarrassed or don't feel bad if you didn't perform all that well. I've always liked to get my students at Hopkins to stand up and explain all this, and they'd never do much better than you did. So that's just the way it is. And so it's interesting to me how it is difficult to keep the key ideas in clear focus, but it's been a guide for me, and I hope it'll be helpful for you too. Okay, we're now going to break up into small groups, and so I'd like to spend 20 minutes on this in the breakout rooms. And what I'd like for you to do is to address these three questions. And I'm going to ask you to have a reporter, a recorder, and then somebody who can report for your group so we can share what the discussion has been in the small groups. So there are three questions here. Are you now a fan of CBIO or not? The second question, if you're not a fan, why? And if you are a fan, why? And then the third question, for those of you who are a fan, what can you do to advance the cause of CBIO? Is that clear? Okay, so we're going to break up into small groups. You'll have 20 minutes, and then we'll have 10 minutes for sharing the findings of your discussions. So can we break out now?
We can just have one group here. We can maybe ask Trevor to help.
You guys want to have, let's stick with our two groups. You got 4 here.
virtual y entonces vamos a volver a trabajar todo. Puede faltar otros socios, pero la comunidad no. Creo que lo más importante es la comunidad. Entonces, esas fueron las respuestas que nosotros pudimos dar en grupo y creo que la salud pública esta metodología es lo mejor que puede haber y todos tenemos esa experiencia de trabajarla y hemos logrado muchos resultados. Entonces, muchas gracias.
Thank you, Juani. We have a second Spanish-speaking group that was meeting virtually, and Andrew tells me that they're now ready to report. So since we're in the Spanish mode, we'll keep going on that for the moment.
Yuri, her name is Yuri.
Okay, then we have Yuri reporting, and Yuri, I don't know where you're from, but we're delighted to have you.
Hola, buen día. Sí, se logra escuchar. Buenos días a cada uno de los presentes. Pues nosotros nos unimos de forma virtual. Por supuesto, todos estuvimos de acuerdo que somos fan de la MBCOI. Sabemos que esta metodología es un abordaje para los servicios de salud, la cual va a permitir a los proveedores locales entender mejor y medir con precisión los resultados y el impacto que va a crear esta metodología, no solo a nivel comunitario, sino que también a nivel del país. Sabemos que eso se va a lograr a través de la creación de confianza y la generación de lazos con las familias y comunidades. En este caso, nosotros tenemos que dar a conocer a otras instituciones u organizaciones cuáles son los objetivos y los avances que se han tenido en los lugares que se ha implementado la metodología para que ellos puedan adaptarlo y de esta forma también generar grandes avances. Para eso también tenemos que entender cuáles son las prioridades en salud en las comunidades como una metodología holística a través de la concientización y el impacto que genera dicha metodología. Para eso también nosotros, uno de los grandes avances sería la creación de políticas públicas, que estos son actividades en la cual el Estado se gestiona a través de un gobierno y una administración pública. Más que todo va a ser con el fin de satisfacer las necesidades de la sociedad. Comentábamos ahí cuando nos unimos con los compañeros que la creación de estas políticas públicas ayudaría bastante para que más municipios o diferentes países vayan adaptando la metodología y se haya creación de más casas maternas en distintos lugares, la cual ayudaría bastante a la población para la restauración de su salud. Esos de los apuntes que nosotros agregamos solamente y muchas gracias. Buen día.
Thank you very much. That was terrific. So our other group here in the room, our English-speaking group, who is reporting for you? Barbara Mufaletto. Barbara, come on up.
Thanks, Henry. So to the first question, are you a fan of CBIO or not? Our group had a resounding yes. Many of members of our group have had hands-on experience implementing CBIO and have really seen the benefits of the methodology. So some of the reasons we said yes is that it involves the community to identify their own health problems, the ability to track mortality and orient the program to the highest needs. It also empowers the community and sees them as a true partner in project implementation. It is a data-driven methodology, so that not only guided by the mortality data, but also by the data received through monitoring and other evaluation activities. It also works on raising awareness to communities and health workers. So it has this health promotion aspect to it that involves more community actors. CBIO also doesn't begin with bringing lots of new things to communities. It really works with what already exists in the communities in both capacity and resources. And lastly, it is a bottom-up approach, and we conduct it alongside the community. So some kind of overlapping ideas there, but wanted to mention them each distinctly. During our conversation, you know, we talked about some of the like the more like I guess negative aspects or issues that exist with CBIO. As you know, nothing is perfect, and you know, we hope that from this training we will have a community where we're continuing to learn about and grow and improve on the methodology. Some kind of like areas where CBIO could have some improvement is that it just it takes a lot of time with project startup. And with talking with Henry, he said, well, we could start care groups earlier. Like there could be things that are done closer to the beginning of the project that are workarounds. And so this is perhaps an area where we can learn more about. Also, it was mentioned that from our implementers that at first the CBIO seems really easy. It seems like it just seems easy, but then you start getting into implementation and it becomes very complex very quickly. It's a very broad methodology, and so there's lots of new things that you're starting at once and lots of new systems you're putting in place. And so with that, making sure that we are documenting and sharing what the templates that we're using, the systems we develop, so that it can become easier for others to use it. There's a high volume of data to manage, and so digitizing our data would be a potential solution for that. Again, making it a lighter lift to implement. And then lastly, it's a little bit unknown about and we assume it's going to be difficult to implement in a peri-urban area. Because of it doesn't have necessarily the best conditions for CBIO, a lot of in and out migration, the lack of sense of community among people in there, and the lack of traditional community structures. So we're hoping that will be, that we can learn more about that from Ramiro and CSRA's experience, as well as experience from our partners in Haiti. And of course, I'd like to say again, we are big fans of CBIO. So the next question about what can we do to advance the cause of CBIO? And we talked about the potential of looking at adding it to existing programs. We recognize that CBIO might be a difficult sell to funders who are unfamiliar with the methodology or have very short funding cycles. And so how can we maybe add CBIO to an existing project and kind of speed up that initial implementation, and also test it out and gain more trust in that area? Specifically, they mentioned maybe some randomized control trials. And other things we'd like to do is training and demonstration to local governments and other CBIO actors on CBIO. And then lastly, what can we do to advance is, to assist with the proper marketing of CBIO. And we see that you've already got it branded with this like really beautiful logo and whatnot. So I think that there's great movement going on in the area, and we'd like to assist too.
Thank you, Barbara. So Barbara's comment, Barbara's comments bring to mind what I said the first day. Theory and practice are closer in theory than practice. But having said that, I still believe that theory is very important, and to have the principles in mind, and as the situation brings itself to create possibilities, having the theory in mind, the principles in mind, may present opportunities to apply the theory in ways that you might not have thought about if you don't keep the theory in mind. So great, thank you. So now we need to hear from our other groups who have met virtually. So who is reporting from actually, Saeed Arwal, our dear friend from Afghanistan, is raising your hand. So I guess you're reporting for your group. So go ahead, Arwal.
Yes, good morning, and I'm sorry that during the groups, I do not understand in which group I am, but no problem. I will share my idea about that very, very shortly. I would like to say that we all are believe on primary health care, and primary health care is the best strategy for the health for all. So therefore, we believe that, and we are working in worldwide for that. So the best strategy for the implementation of the primary health care is community active participations. So for the community active participation, there are different tools. One of that is very important and best tools, what I understood, that is CBIO. So it means we are agree and we are in this side, so we have to follow this and we have to learn. And this is very important because this is, if we believe the three-way partnerships, important partners is community by itself and beneficiaries. So we have to work with them, by them, and with them. So that's very important approach of CBIO. We are agree with that, and we have to follow. And we would like to request that it should be not only work only in some countries. So let us do sometime. Hopefully, if there is international community-based healthcare or community-based community engagement, any workshops or conference. So we share with all the people who are working for the community engagement and community empowerment. They should understand the CBIO, and we should provide the training material for all of them. I mean, Dr. Handy Piri and his team, and we should work together for that, how we can implement that. That's very important approach for the community empowerment and community engagement. Thank you so much.
Hear from, we have at least one other virtual group, so can we hear from you?
Hello. I'm speaking on behalf of English 1 group.
Hello. Okay.
So from our group, we were 6 of
Tell
us.
us who you were. Tell us who you were, please.
I'm Austin Angerson from Malawi.
From Malawi. Very good.
In our group, most of the members, for the first question, are you a fan for CBIO? Most of them said they, though it's their first time to hear about the CBIO, but having learned this methodology through this workshop, they are now a fan of CBIO. And the reason being, one, some of the things that we have learned, like care group, where most of the members in my group were already doing that at the ground, like for example, care group. So it's just a matter of incorporating some of the concepts and principles of CBIO into already existing projects, and also adapting it to the community they are working. Because this approach is good because it's a bottom-up approach other than a top-bottom approach. So it's a way of reaching people directly and having time to get real-time data to really get the situation at the ground. So that's a very important tool. And also on the other side, we are still in the process of learning. As I said, most of the members in my group, it's their first time to hear about the CBIO. So we are still in the process of learning. There are more things to understand about the tool approach of CBIO. Like, for example, maybe what it means to implement at the ground. For example, collecting mortality rates periodically and tracking mortality and visiting households. That, how does it feel? What does it mean to do that at the ground? So we need to understand more from those already at the ground doing the CBIO, so that we can have a great picture and a clear picture of what it is before we maybe fully adopt it. But some of the components of CBIO, in many of the projects, like, for example, care group, they're already incorporated, and they are helping indeed in the implementation of the project. In terms of how we can advance the CBIO, it is through documentations. Those doing the CBIO at the ground, they need to document the results and share, so that anyone will be attracted to the results that are changing the community, that are transforming the community, and that are helping the community to have a better life and to improve their health. So through sharing of those results and documentations, that will enable many of the organizations to adopt and to advance the CBIO, and also to share this methodology of how to do it at the ground practically. And again, it's also a matter of this other side to seek information to those who are doing the CBIO. Like, it's not only to wait for them to share the results, but also those who are not doing it, they can also seek information. For example, to visit somewhere like where the CBIO project is being implemented, and to see how they are doing their project, and to feel and to see, to observe how that look like, and what does it mean to do at the ground. So that will help much to advance the CBIO. Thank you.
Thank you very much. Is there another group that hasn't reported yet, or is that it?
Yes, Prof. This is English Group 5. This is Samuel.
And where are you from, Samuel?
Okay, originally I'm from Ghana, but currently I'm based in Deutschland, Germany.
Very good. We're glad to have you.
Okay, so can I share my screen?
Yes, we can see you. Thank you.
Yes, so I just want to share my screen. If the moderator can allow me to share my screen.
Just a second, we're working on it.
Okay.
Try again try sharing your screen again. We can see your face, but we don't see your screen.
Okay, Prof. Okay, I'm trying to share again. Okay. Okay, it works, yeah. So,
okay, we can see your screen. Terrific. So make it, you know, a full screen PowerPoint slide there. It's kind of, there we go. Perfect. Great. Congratulations.
Thank you. So, good afternoon, good morning, good evening, depending on your location. So my name is Samuel. I'm presenting on behalf of English Group 5. So we actually were 10 in all in our group, and we all agreed that CBIO approach is a good approach, and we report that we actually are fans now. I think two of us, three of us were really had a proud experience of CBIO. And so going to during the discussion, it came out clearly that the approach at the presentation went over the past 3 days help really in identifying or helping in detecting unreported mortality, which is very important. Sometimes we have our data reported in terms of rate and ratio to just sell whether we are doing good or bad at the country level. But you go to the community level, there are a lot of children dying, mothers dying, and then these are not reported. But once we adopt CBIO approach, it actually reveals all those things, unreported data, and is appreciated at a partnership level. Based on that, the second point under question 2, we also agree that the implementation or data collection tool has or packages has actually improved, like we saw in the presentation yesterday. The local birth package 2 and the verbal autopsy tools has really improved, and it's a remarkable enhancement for CBIO approach. The third point that we discussed in a group, that the community perceptions, when you actually adopt this approach, community perceptions regarding service interventions are diminished, and which is very important because the communities are involved in identifying the challenges and also coming out with solutions to support service delivery, which some of the issues could be a cultural barrier, and we cannot solve that problem when you don't really engage the communities. And so when the communities are part of identifying the issues in terms of why the children are dying in real time, why mothers are dying in our community, they help in resolving those issues. The third aspect where we actually discuss looking at how can we then advance CBIO if we all agree that we become champions, we are now fans of CBIO. One, we agree that we keep sharing the success story on CBIO. 2, we say that we data collection tool need to be transformed, need to be digitized, which is very important. And my other presenters, previous presented emphasize on that. The third point, we need to incorporate the CBIO approach into other community-based public health interventions such as nutrition intervention and HIV and others you can think of when you talk about public health intervention at the community level. We need to integrate it. And so CBIO need to take the lead in identifying the issue before we actually go in there with all the strategies, because it unearths the issues. The next one that we actually agreed in our team is that we need to identify and train and mentor CBIO champions across different country levels that can also sell the concepts across as we've started. We had the success stories from Kenya during this presentation throughout these 3 days. We also agree that we need to keep sharing, we need to incorporate CBIO approach into other community-based intervention. Okay, yeah, so I end here, and thank you very much for listening. Over.
That's great. You had some repetition there, but
yes.
that was terrific. So we give you an A+ on that. you had a lot of great points and you had a wonderful way of sharing that. So congratulations, Samuel, and you've made some very excellent points that I think will help us all as we think about this. So I think we've had all the groups report now, haven't we? Are there any other groups that haven't reported? Okay, well, we've come to the end of our first session, which is reflections on our work so far. So we're running a little bit behind, but that's okay, we can adjust. So we're going to take about a 2-minute break, and then we'll transition into the next session, which will be evidence on the effectiveness of CBIO, and also a PowerPoint that Ira Stalick has made, which I really like a lot, about why we should be fans of CBIO. Get back in your seats and we'll move into the next session. So what I want to do now is hopefully inspire you even more about the value of CBIO and share with you some of the experiences of what I consider to be pioneering programs that have utilized CBIO principles. They may not have called it that, but in essence, that's what it is. So I want to share with you some examples, and want to focus particularly on some of the achievements in improving coverage of key interventions that we know are important for reducing mortality, and also some of the evidence again on mortality impact that some of these programs have been able to achieve. So I want to mention these specific projects and programs. So we heard from Abhay Bang on Monday and his amazing program at Search and their success in reducing neonatal mortality. We haven't heard about one of the other great achievements that Search has had over the years, and they were one of the very first projects to demonstrate that community health workers can diagnose and treat pneumonia, childhood pneumonia, and reduce mortality from childhood pneumonia. So we'll try to mention that in a minute. The MUSO NGO in Mali, we heard Ari Johnson on Monday talk a little bit about their work. We're going to share a little bit more about that. We're going to show a terrific video about the BRAC urban slum project. So we've heard various people talk about the challenges of developing this kind of approach in an urban slum setting. So I hope that hearing about what BRAC did with its urban slum project will be inspiring for you. I've mentioned the JomKed project off and on. The JomKed project was a pioneering pioneering project that implemented the CBIO principles, but they didn't call it that. But like the Bangs, Raj and Mabel Aroli, who started the JomKed project in 1970 in India, they were students at Johns Hopkins right about the time I was a student at Johns Hopkins 53 years ago. But they were inspired by Carl Taylor, who I've mentioned off and on. And of course, Carl Taylor, as I mentioned, was a close friend and colleague of John Wyan. So we've got this network of personal influences that have had a dramatic impact in a lot of different ways. And as I mentioned before, the JomKed project was one of several inspirations for creating what today is the largest community health worker program in the world in India, with more than 1 million ASHA workers accredited social health activists. And Roger Rowley was an influential national figure within India to help move this concept forward on a national scale, in the same way that Abhay Bang is now an influential person at the national level in India, but also internationally because of the power of his program and the evidence that they have produced. I'm going to talk a little bit about the Hospital Albert Schweitzer. I mentioned that on Monday. The Hospital Albert Schweitzer is in Haiti, and I had the privilege of visiting there in 1979, and that visit proved to be transformational for me because I had a chance to see firsthand the community-based work of the Hospital Albert Schweitzer that were started by Warren and Gretchen Berggren, who later became dear friends of mine. And then through their friendship, I came to know John Wyan, who ended up being a long-term mentor of mine personally, but also the brains behind CBIO. So I will always give him credit for the ideas of all of this. And it was a wonderful opportunity that I had to work with John Wyan, but also I've had a very interesting career and I'm very grateful for it. But later in my career, I had a chance to go back to Haiti, and I lived there for 4 years as the director of the same organization. And so during that time, we had a chance to consolidate and publish some of the experiences at the Hospital Albert Schweitzer, which are very important. I'm going to show a little bit of that. Then we're going to talk a little bit about some of the Cure Americas experience again in Bolivia, Guatemala, Liberia that we haven't talked much about, in Kenya. And then finally, care groups. So I guess we could spend the rest of the day going through this, but I will try to move ahead with this. So SEARCH, it's an acronym that stands for the Society for Education, Action, and Research in Community Health. So to me, whoever came up with that acronym is brilliant, and it was Abhay and Ronnie Bang who came up with it, and they're brilliant people, as I'm sure you appreciate by hearing them talk on Monday. I've been to SEARCH several times, and here I am taking a picture of Abhay and Ronnie Bang with Carl Taylor, who was their mentor, in the same way that Carl Taylor was my mentor as well. This was, as I mentioned, I spent 5 years working at Future Generations, which is a small NGO, and I was the Carl Taylor Professor for Equity and Empowerment at Future Generations. And Carl Taylor was 88 years old when I started working there. His son was the founder of Future Generations, but Carl was devoting virtually all of his time at that moment with working with Future Generations. So I traveled all over the world with Carl, and we went together to JOMCAD and also to the SEARCH program. And so here's a picture of Carl with the Bangs. So this is my interpretation of how the Bangs applied CBIO principles. As we heard Abhay say on Monday, he doesn't call it CBIO, but everything that is important to CBIO, they're applying there. And of course, they've been there for 30 years now, working in a population of 80,000 people. So it's not a big population, but they, as Abhay Bang said, through their research, they have proved Archimedes' principle. Does anybody remember what Archimedes' principle is from Abhay's speech? Another exam question. No, this is the last day, so it's final exam time. So who can remember what Abhay Bang said about Archimedes' principle? This is very important. Can somebody join in online? Just unmute yourself and tell us. Were you awake when Abhay Bang was speaking? That reminds me of the definition of a lecture. A lecture is a series of words that pass from the tongue of the professor to the handwritten notes of the student without passing through the minds of either. So I'm wondering whether what Abhay Bang said actually went into your mind or not. So Pat, are you raising your hand? Okay, Pat wrote it down. It didn't go through her mind, but she did write it down. So she's going to come up here and read it to you. So it still might not have entered her mind, but at least she wrote it down. So Pat, come up here.
So I wrote down.
Get up here.
I wrote down two things. I have no idea if either one of them is attributable to Archimedes. One of them is go where the problems are and not where you are the problem. I'm sure that was not Archimedes, but it's a good quote. And the other one is listen to the people and what are their problems or about their problems, something like that.
Pat,
One of those, right?
Pat, thank you so much, but you made an F.
Wait, research on the people. I wrote all kinds of things down, but none of that.
Anybody else want to give it a try? No? I'm disappointed. Your professor is disappointed, and you're.
I wasn't here, but it's principle. It's a physical principle of water.
No, that's a different one.
Okay.
Okay, so the Archimedes principle that Abhay Bang said is give me a lever long enough. Anybody remember that now?
And then you
Give me a lever long enough. Is somebody trying to help me out here? Huh?
And you can move the world?
Yes. Give me a lever long enough and I can move the world. Do you remember that? Okay, but the application of the law to our situation here, does anybody remember what that was? How does that principle apply in our situation and in fact in the Bang situation? So what he said was with the evidence that they generated in Gacciaroli, they were able to move the world. They changed the policies in Washington, New York, Geneva, with a small population of 80,000 people, but with the evidence they were able to show. So Abhay considers research to be the application of Archimedes' principle. And I think that's got a lot of relevance for our work because, as various people have said, the more and the better evidence that we can produce about the effectiveness of this approach, the more likely we are to advance the procedure forward. So there is value in the writing and the documentation and the publication of experiences with this, and there is great value in that. And so I want to emphasize that as well. But anyway, I won't go into all these things that you see here, but only to mention, and Abhay Bang mentioned this in his talk, the priorities they identified early on. The first priority, the first epidemiological priority they identified early on was childhood pneumonia. And they developed their own approach to addressing that epidemiology. He was one of the very first people to train community health workers to diagnose and treat pneumonia. And they also published this in the Lancet, and this article was also cited by the Lancet as one of the most important articles ever published in the Lancet. And they showed, because they had a comparison area and a control area within their 80,000 population, so their intervention was 40,000 people in the intervention area. The control area, they had 40,000 people. They had the vital events registration system operating in both at very high quality, and they introduced the intervention of training their community health workers to diagnose and treat pneumonia. And they showed that they were able to reduce the under 5 mortality by 1/3 using this intervention, and it changed global health policy and is one of the foundations of what today is called ICCM, or the Integrated Community Case Management, which includes the childhood treatment, the recognition and treatment of childhood pneumonia, which is the leading cause of death among children under 5 throughout the world. So this is a pretty important thing, right? And then, as I mentioned yesterday, the people themselves identified alcoholism as their own priority, which didn't surface as an epidemiological priority. So the search program put a lot of time and effort into working on a collaborative program to address alcoholism in their community. So this slide repeats what I just said. And this is their pioneering article that was published in 1990. So that was 33 years ago now, I guess. But another interesting thing is that home-based neonatal care and the community case management of pneumonia by local community health workers is still not widely practiced throughout the world. It's an amazing thing when we know how effective these two interventions are, but how limited is the application of this knowledge to save lives of children around the world. It's absolutely extraordinary. There is progress. Yes, there is progress, but it's nothing close to what it could be or should be. Their work on home-based neonatal care is located in this journal supplement of the Journal of Perinatology. It's available online, and all of these resources will be available to you through our website. But I think this is one of the most important series of articles in global health. I think there are 10 different articles, but it describes in great detail all the various aspects of home-based neonatal care and the effectiveness of it in improving neonatal health in their context. And again, this, what the Bangs did shows the power of well-conducted research in a small population. And of course, they're geniuses and they're brilliant people, but other people can learn how to do this type of thing after learning from the Bangs as leaders, but other people can learn these sorts of things as we move ahead. So, Abhay showed this slide before, but I want to mention again the value of having a strong baseline before you begin to assess the effectiveness of your program. And so in this case, they had their program going on and they were making progress. But then when they started their home-based neonatal care program, it was an intervention that was applied within their broader project area. The intervention took place in the intervention area, and they had the control area as the comparison area, which made for a very convincing presentation of effectiveness. So Abhay Bang grew up in Gandhi's ashram. His father was a follower of Gandhi, and I'm going to show a video, a 2-minute video from Abhay that tells a little bit more about this. But this is one of Abhay Bang's great quotes that he brings in whenever he can. And by the way, as I'm thinking about it, if you look up Abhay Bang, he's got all kinds of videos on TED Talks and on and on. So if you have time and interest, you can certainly get more inspiration from Abhay Bang. But when Gandhi is talking about the weakest, most wretched and miserable human being that you ever saw, he's talking about neonates. They're human beings. It's a human life. And look what he did in saving the lives of neonates. So part of the success of home-based neonatal care is based on the fact that a community health worker visits every pregnant woman before the birth takes place and provides some education and orientation. And then the woman who still gives birth at home, she notifies the community health worker that she's in labor, so that the community health worker is there with the traditional midwife at the time the birth takes place in the home. And then the community health worker's job is to attend to the newborn. That's the way this works. And so they've been taught how to manage neonatal asphyxia. So if a baby is born not breathing, then the community health worker has what we call an ambu bag and can resuscitate these newborns that aren't breathing at birth. They all can't be resuscitated, but a large percentage of them can. And then all the behavioral things that go into reducing neonatal mortality, of course, are practiced there. Early and exclusive breastfeeding, the prevention of hypothermia is an important part of their intervention as well. Identifying low birth weight babies. So this is another key aspect of the intervention, because low birth weight babies are much higher risk of death than newborns who have normal birth weight, and they need special attention. So in their program, if a low birth weight baby is born, then they have a protocol in which the community health worker comes to the home of that mother much more frequently than they do for children who are born with a normal birth weight. So these are just examples of the technical components that make it possible to reduce mortality. So early treatment and referral of neonatal sepsis. So in the Jomket case, they trained their community health workers to administer intramuscular gentamicin. And, this is a fairly high-powered medical treatment. Gentamicin is a high-powered antibiotic, but if you give too much of it, it'll cause deafness and renal failure. So it's a toxic drug if it's not given in the right amount. And Abhay Bang got the professor of pediatrics at the most prestigious medical school in India to come to Gachiroli and confirm that his community health workers knew how to do this and do it well. It was controversial. The other programs that have been developed later in the international recommendations for home-based neonatal care do not include the administration of gentamicin. And so he carried this a step further than most people felt was comfortable or appropriate for widespread application. So, this work that Abhay Bang did was picked up by other programs in other places where they applied these principles, but without the gentamicin. And Abhay Bang was able to show a 70% reduction in neonatal mortality. The other studies showed a third reduction or 25% reduction. So when there were 13 studies of all of this that were done and meta-analysis, which is a combination of all the data from all these studies, it showed a 24% reduction in neonatal mortality, which is still spectacular when you get right down to it. And this has been published, of course. It became the basis for the global recommendation of home-based neonatal care in places where home births are still very common. So this is the UNICEF and WHO recommendation. You need to take it off mute.
I have the link if you want me to go.
Thank you for work.
What would I do without you?
Send you an invoice.
There are different types of pleasure one gets doing math.
We would be lost without Andrew Herrera. So Andrew told me he'd send me an invoice.
We have to mute your microphone and then do this.
Cut my microphone off.
Mahatma Gandhi, once when my father went to seek his blessings, my father was a young economist and who was planning to come to the US for doing his doctoral studies. And he went to seek Mahatma's blessings, and Mahatma looked at him for a few seconds and said, that young man, if you want to study economics, go to the villages of India. Search probably has find out a place for itself by combining going to people, identifying health problems which people feel that they are problems, not because some university professor feels or some journal has that possibility of publishing. On one side, the local people get health care for their problem, but because everything is done as research, it repeatedly has produced research outputs which have been plowed into the national and international health policy. So in a way, act locally, but think and influence globally. Our another emphasis has always been that whatever research we do has to provide benefit to the local population. Third thing, that healthcare or solutions that we try to develop invariably aim at empowering the local communities to take care of their own health problems. Go to the people, live amongst them, love them, listen to them, learn from them, and begin with what they know, build upon what they have. That probably very neatly summarizes how any activist, any researcher can solve the problems, and that's what we are trying to follow. His blessings.
Oh, can you hear me online now? Okay, good. All right. So this is the slide that reflects what R.A. Johnson spoke about in his keynote address. This, to me, is one of the most spectacular slides that one could imagine if you're interested in saving the lives of children. And you can see here the black line and the dotted line are the national averages in terms of slow decline and under 5 mortality in Mali, where Abhay Bang's program was in a peri-urban area. I want to emphasize that. We've talked about this. And you see the yellow curve there, that's the mortality measurement that they made in their program area. This was not a large program area, so I forget the exact size, but it was like 80,000 people, something like that. It wasn't small, but it was not huge either. And you can see the dramatic decline. So the cynic could say, well, maybe there was some other influence that led to that decline, which wasn't the program. But when you look at what the program did, it's hard to imagine anything else that could have produced that besides the program. And as you remember, their methodology they call pro-CCM, which means that they have a community health worker that's going to every house, and the frequency is not rigid. And I've tried to understand a little bit more about this, but they have paid community health workers who are going to every home on a frequent basis. And it varies from community health worker to community health worker how often they're going, but they're going to every home and they're looking for children with signs of illness. Newborns, who were lethargic. That's one of the warning signs of serious illness in a newborn. If they're lethargic and not feeding well, then there's something wrong. If a child has diarrhea or if a child has rapid breathing, you know, these are serious warning signs. And so they've trained these community health and also signs of malaria as well. So the community health workers have been trained to provide immediate treatment, but they've also worked out a system so that that child can get to a source of care of higher level medical staff who can provide additional medical support to the condition. And so you can see the dramatic results. And of course, being in a peri-urban area, they had the benefit of having health facilities that were not that far away. I don't know the details of how far it was, but obviously it wasn't like a rural area where you have 3 hours to get to a health facility. And also, I want to repeat what I said yesterday, or maybe I'll ask if anybody remembers what I said yesterday. Does anybody remember what I said that I heard through the grapevine that the founder of the Gates Institute, Bill Gates, has said when he read this article? Does anybody remember what I said about that? Besides Andrew? Okay, come up here, Kevin. I can't verify that this is true, but I think it's very likely that it was true.
I hope I remember the right thing. Yeah. So Gates say that if these are the results of the work you're doing, then all of the funding from Gates Foundation should be given to Cure Americas to implement this.
Oh my, how I wish that were true. No, that's close, but not quite it. So what Bill Gates said, and I'm sure Cure Americas might have benefited from this if he actually carried through. But what he said, according to what I was told, is that if these results are really true, then the Gates Foundation should be pouring all of its resources into implementing this approach. But does anybody remember why the Gates Foundation didn't do this? Somebody can answer online. Please. I'm going to call on somebody. No. Nobody remembers? Again, confirming my basic principle of what a lecture is. Didn't make it into the minds of people.
They didn't believe it to be true.
Correct. Thank you so much. I don't know who that was, but that was terrific. Who? Oh, Harriet. Great. So there's another step that follows from this, which I'm very curious about. And this was published in 2018. And in fact, they published earlier, and I forget what year it was exactly. They published 3 or 4 years earlier their early results that showed this when the curve was early on. So my question is, why haven't other groups replicated this? And why hasn't the Gates Foundation why haven't there been other groups who want to replicate it? And why hasn't the Gates Foundation provided funding for that? I think that's a very important question. If you think about some new cancer treatment that showed results like this, just think how many other groups would be replicating and how much money there'd be out there to replicate this. But look at what's happened here. There's something tragic going on here. Again, it's to bring back the low coverage of home-based neonatal care in areas where home births are still dominant, the low coverage of community-based treatment of childhood pneumonia by community health workers with proven interventions. There's something wrong because we're not extending these very basic and simple and inexpensive interventions to save the lives of people. So now we're going to switch to BRAC. We had a presentation, a brief discussion of BRAC as an organization more broadly, and we had a brief opportunity of a discussion with Morsheda Chowdhury, who is the Director of Health for BRAC in Bangladesh. But I want to talk about one specific program that BRAC has been running, and it's called Manoshi. Manoshi is a combination of three Bangla words, Bengali words for mother, newborn, and child. And so they got a $25 million grant from the Gates Foundation a number of years ago to begin this work. And BRAC's principle of operation is that they don't develop anything, they don't implement anything, or they won't continue with it, and they won't scale it up unless they can sustain it with their local resources. So Manoshi, with this $25 million grant, was a startup grant to establish a program for 8 million people. So $25 million for 8 million people is really not much when you think about the scale of the program. But they developed this in a way that they could sustain with their own resources for the longer term. So this has been running, I think, about 20 years now. And it involves, as I mentioned before, mapping and routine visitation of all homes to identify pregnancies and to trigger the Shasta Shabika is the low. I mentioned the dual cadre system that BRAC has. So the Shasta Shabika is an unsalaried volunteer with minimal incentives, community health worker. These are all women, and they're visiting every home on a regular basis. And when they identify a pregnancy, then they call on the Shasta Kormi, who is the higher level community health worker who's salaried and works full time. She goes to that house and provides education and training about prenatal care and does a quite sophisticated prenatal care visit in the home, checks the blood pressure, looks for protein in the urine, and she does this several times during the pregnancy. And she also motivates the mother to come to what are called birth huts. And I mentioned this yesterday, and it's very analogous to what we've done with Cure America's Guatemala with their local birthing centers. And I've been to some of these birthing huts. They're simply a room in a slum. They rent, the slum people live in a one-room place, right? So they rent a one-room place, and they hire two traditional midwives who have been working there. BRAC hires two of these people. They provide training and supervision. And so 24/7, one of these traditional midwives who is now an employee for BRAC is available at this birthing center. And they provide guidance and support at the time that a woman comes for delivery. And there's these birthing huts they develop for 10,000 people. So every 10,000 people, there was a birthing hut. So they were very close by. And one of the things I learned about Bangladesh, and I don't know how common this is around the world, but in places where there are home births, it's quite common for traditional birth attendants to give intramuscular oxytocin, which is a very dangerous thing to do if it's not given at the right time for the right reasons. And so, like, one of the things that these traditional birthing attendants do is they keep these women in labor from receiving intramuscular oxytocin. Anyway, just a small point. So they were able to make substantial improvements in the neonatal mortality rate and the maternal mortality rate at a very large scale using this approach, which involves CBIO principles. It doesn't involve all of them, but it involves important CBIO principles. So now I want to show you this video. I have to warn you that it's going to stop abruptly, and I'm not quite sure why that is. It wasn't my editing that messed up this time, but it's just, oh, Andrew said slow down, sorry.
Night. Late at night. Shumi is struggling with severe labor pain. Along with this, she is also bleeding. Her close relatives and neighbors are trying for the delivery, but none of them has thought of taking her to the hospital. The situation gradually kept getting worse. There is no money, no transport to take her to the hospital. Many difficulties are there. And at last, when everything was arranged, Shumi was no more alive. Her unborn child, too, could not see the light of this world. This is a common scenario in Bangladesh. Each and every day, numerous Shumis and their unborn babies are facing untimely deaths in a similar manner. And most alarming of all is that the number of maternal deaths on an average is approximately 12,000 per year. In Bangladesh, a country with an area of 56,000 square kilometers, frequent natural disasters and the stress of rapid population growth are pushing a segment of the population into extreme poverty. Unable to cope with this poverty, a certain group of the population is migrating to the urban areas for a better livelihood. These underprivileged, poverty-stricken people are taking shelters in various slum areas in the cities. It is noteworthy that 1/3 of the urban dwellers live in these slums. Here, even their fundamental rights are denied. The people here are deprived of some of the most basic rights, such as access to pure water, sanitation, education, etc. In the urban areas, the high costs of living have kept proper healthcare facilities out of their reach. Hence, even though there are government and NGO healthcare facilities available nearby, the slum dwellers are not able to take advantage of them. 80% of deliveries in slum areas take place at home and mostly in the hands of untrained birth attendants. The unavoidable outcome of this has been an increase in the maternal and child deaths in the country. Along with the government of Bangladesh, BRAC has also come forward to combat these problems with other fundamental issues. BRAC has been working all over the country since 1972 for the advancement of the impoverished. Through the implementation of various nationwide program activities, BRAC has been successfully working for the economic emancipation of the poor, women's empowerment, establishing justice and good governance, ensuring education and healthcare, as well as many other initiatives to stop social injustice and disparity. At present, around 10 crore people are getting benefits from BRAC's various programs. In an effort to continue this, BRAC has undertaken a project called Manushi for addressing health of deprived mothers and children living in urban slums. BRAC has expressed its solidarity with the national commitment to achieve the Millennium Development Goals by reducing maternal mortality by 3/4 and child mortality by 2/3 by 2015. The prime goal of Manushi is to reduce maternal, neonatal, and child mortality by providing integrated health services through a coordinated community-based health program in the urban slum areas. This project is being implemented to cater to 8 million urban slum dwellers. Manushi is providing necessary health services to pregnant women, postpartum mothers, neonates, and under 5 children. The objectives of this project are, among the urban slum dwellers, to increase awareness about maternal, neonatal, and child health, to ensure health facilities by developing skill of the health workers, to involve community people with the project to strengthen the healthcare system, to consolidate the referral system with government and non-government health centers and keep them effectively functioning, to implement and expand the GO and NGO initiatives. Nur Jahan Begum is a Shastha Shebika of the Manushi project. Shastha Shebikas, like Nur Jahan, go from house to house in the intervention area, identify pregnant mothers, attend delivery and give essential newborn care, advise for taking special care of low birth weight babies, and gives treatment for diarrhea and ARI in children and provide drugs to adult tuberculosis patients. Besides, they also give treatment for some other common diseases. The principal responsibilities of a Shastha Shebika are thus: to identify suspected pregnancy, to offer essential newborn care, to take special care of low birth weight babies, to diagnose and provide treatment for diarrhea and acute respiratory infections, to provide family planning services and sell health commodities, to give treatment to tuberculosis patients, and to give treatment for general diseases. In the project intervention areas, one Shastha Shebika is responsible for taking care of 200 households. A Shastha Shebika, on an average, visits 10 houses every day. The selection criteria for Shebikas are: a member of Bragg Village Organization, married, aged between 25 to 35 years, age of the last child over 2 years, willing to provide voluntary services. After getting proper training, Shastha Shebikas start working in their respective areas so that they can serve their mothers, newborn babies and children without delay in case of emergencies. A Shastha Kurmi is assigned to supervise the work of the Shastha Shebika. For every 2,000 houses or 10 Shastha Shebikas, one Shastha Kurmi is assigned. Along with collecting the pertinent information from the Shastha Shebikas, the Shastha Kurmi confirms pregnancy and registers pregnant women, gives basic antenatal care, weighs newborns within 24 hours of delivery, gives postnatal care for mothers and newborns, gives essential newborn care, and refers to appropriate health facilities in case of any complication. The main responsibilities of a Shastha Kurmi are to confirm pregnancy and enroll pregnant women, to provide antenatal care ANC, to take the weight of the newborn babies within 24 hours of delivery, to provide postnatal care PNC to the mother and newborn, to provide health care to under 5 children, to refer to the appropriate health facilities in case of complications. A delivery center has been established for every 10,000 people in Manushi intervention areas. These delivery centers maintain privacy and dignity and immediately diagnose complications and arrange their referrals to hospitals. At these centers, 2 trained birth attendants are always prepared to attend delivery. These birth attendants are experienced, willing to work, and selected from the community. They assist in delivery, provide essential newborn, and also identify complications and arrange appropriate referrals. The community midwives supervise and support the birth attendants. The health workers organize meetings with the 8 to 9 month expecting mothers to prepare them for safe motherhood. Two committees, MNCH and Mother Support Group, have been formed by including members from the community. These members facilitate the Manushi activities in various ways to ensure maternal and child health care. In addition to save lives of mothers and children, Manushi also involves local pharmacists, imams, Kobiraj, and other alternative health care providers. Unfortunately, in spite of having all those activities, many slum dwellers are neglectful to seek timely health care. Folk music and street theatres are thus being performed to increase health awareness among slum dwellers in order to ensure health care for mothers and children. To save lives of mothers and children, Manushi has developed an effective referral system with government, NGO and private hospitals. This creates space to offer quality service within shorter time.
It is my personal and professional privilege to introduce our guest scholar this evening, a person that I've known for 18.
You're unmuted.
Yeah. Okay, I apologize for the abrupt stopping of that, but I think we can all agree it's a very powerful video that shows what BRAC has been able to do, but what can be achieved at scale by applying principles of CBIO and routine systematic home visitation. I want to just share a little bit about the JOMKID Comprehensive Rural Health Project. As I mentioned yesterday, when Raj and Maybell Aroli started this project in 1971 or 72, they followed the model of Dr. Carl Taylor's with the Naringwal project in North India, in which they had paid auxiliary nurses to visit the homes of people on a regular basis. And so the Raj and Maybell Aroli, they hired auxiliary nurses to work in this very impoverished, isolated area of India. But what they found out was that these auxiliary nurses were people from larger cities with training, and they didn't stay with the project because they went back to where they came from. They were different culturally, educationally from the local people. And so the Arolis had to make an adjustment. And what they did was they decided to train local illiterate, many of them Dalits, untouchables, whom they had been working with because they had been sick. Many of them had tuberculosis and were dying. Many of them were widows. And the Arolis had a relationship with these women. And so they started training them to be village health workers, going to every home and attending births and providing treatment very much like you saw in the Manushi project. And these are these women And these women continued to work their entire lives. Some of them have now retired, so a few have died, but there's still women there now that have been doing this for 30 years. And so if you're talking about sustainability, you know, this is a pretty strong approach that is sustainable with local resources. And so this is what the Arolis were able to achieve in the JOMCAD project relative to demographic and health survey data for the state of Maharashtra, which is also where the Bangs do their work. But it's very impressive. Unfortunately, unlike the Bangs, the Arolis never published this in the Lancet or a scientific journal. They've written a book which has been translated into 7 or 8 different languages and has been read all over the world. And I always tell my students, if you want to learn something about global health, read the book by Raj and Maybell Aroli called JOMCAD, A Comprehensive Rural Health Project. And it's one of the best writings about global health that I know of. And so the access to this will be on our website too, of course. But just to repeat again, recognizing that a lecture are words that pass from the tongue of a professor into the handwritten notes of a student, repetition is the secret to learning. So I'm going to repeat this again, just in case you didn't catch it the first time. This project, which started on a very small basis, maybe 50,000 people, they did expand it to a much larger population. But this small effort turned out to be the inspiration for what today is the world's largest community health worker program. In India, has more than 1 million ASHA workers, accredited social health activists. And so also, I mentioned yesterday, I'm going to repeat this again, recognizing that repetition is the secret to learning. We have a book that's available online, and you'll be able to get this through our website. We didn't send it to you yet, but I think it's an important resource. It's a written description of 29 national community health worker programs, and the one from Afghanistan that Arwal was a part of is well described in there. So it's 468 pages long, and you'll see that routine, systematic home visitation is becoming a more important part of national community health worker programs. So I've mentioned before that I had the unique privilege of visiting the Hospital Albert Schweitzer in 1979. And that hospital was established in 1956 by a very wealthy American couple who were from a very wealthy family, and their names were Larimer and Gwen Mellon, M-E-L-L-O-N. And Mellon is one of the names of a very wealthy family, a set of people in the United States, much like the Rockefellers, but the Mellon Bank, so forth and so on. So Larimer Mellon was a member of the Mellon family, and he became a black sheep, wasn't interested in banking and making a lot of money. And at age 37, he read about Albert Schweitzer in Life magazine, and he was a rancher in Arizona. He was inspired by what Albert Schweitzer was doing, and he decided at age 37 that he wanted to follow in Albert Schweitzer's footsteps. And so he finished college. He was a brilliant man, but he dropped out of Princeton after a couple of years. So he finished college. He went to medical school at age 37, did an internship. And while he was doing all that, he sent his wife to Haiti to supervise the construction of the Hospital Albert Schweitzer. And so in 1956, he finished all of that. So he started that in 1947 when he decided to do this. So he spent quite a few years preparing himself at midlife to start this. So in 1956, the hospital opened, and he spent the next 10 years operating a hospital in rural Haiti with these very poor people here. But after 10 years, he decided that he was not going to really be able to help these people if he didn't start a community health program. And so he went to Harvard and asked the dean of the Harvard School of Public Health if there was somebody there that could help him start a community health program, outreach services to complement the hospital care that the Hospital Albert Schweitzer was providing. So this was a hospital, and he was spending $1 million of his own money back in 1956 in the early 60s. That would probably be easily $10 million today. I don't know, but it's a lot of money. He was investing his own personal income as a member of the Mellon family to run this hospital. But he decided after 10 years that they weren't reaching the people who needed basic and essential services. And so he went to Harvard. He found a couple named Warren and Gretchen Berggren, who had been missionaries in the Belgian Congo, who had been doing medical curative care in the Belgian Congo. And they had decided they needed to learn public health and work through a public health paradigm rather than a curative hospital paradigm, which is what they had been doing. And interestingly enough, when they were in the Belgian Congo doing hospital care, a very famous man came to work with them named Everett Koop. So some of you may know who Everett Koop is, but he was a very famous figure. He's passed on now, but he was a very outstanding pediatric surgeon who became the Surgeon General in the United States and was widely recognized as an authority figure in health matters. So here he is, a surgeon. He was volunteering to go to work with missionaries in the Belgian Congo and working with Warren and Gretchen Berggren. And he told Warren and Gretchen Berggren, if you really want to make a difference, you got to study public health and get out of the curative medical paradigm, which is what they did. And so then there they were at Harvard. They spoke French, having worked in the Belgian Congo. And Lorimer Mellon convinced them to come to Haiti to start a community health program there. And while they were at Harvard, the Berggrens had become close to John Wyan. Does anybody remember who John Wyan is? So I hope that that name rings a bell by now. I'll repeat it again. John Wyan, he was my mentor and the brains behind CBIO. But the Berggrens asked John Wyan to help them as they started their program in Haiti in 1967. And so these are just a few shots from the Hospital Albert Schweitzer in Haiti. I guess it's just one shot. But the Berggrens developed a system of community health workers called Agents de Santé, who were visiting every home on a regular basis. And then they had a mobile health team that went out to these isolated villages to provide basic and essential services. And they, and at that time in Haiti, neonatal tetanus was the cause of something like 15% of all infant deaths were from neonatal tetanus. And it had just been demonstrated that a vaccine given to mothers would prevent neonatal tetanus in newborns. And so they were world famous because of their pioneering efforts to get every woman in this much larger area than the Hospital Albert Schweitzer service area, get these women immunized against tetanus with a dramatic impact on under 5 mortality. So you can see here when the Berggrens started work in the mid-60s, they were able to have a dramatic impact on under 5 mortality. And that, when they got down to a level of about 50, it continued at that level. But when they published their, as I mentioned before, when they published their results in the New England Journal of Medicine in 1981, they demonstrated that their under 5 mortality was 1/4 of that for the country of Haiti. So it was one of the things that inspired me into this line of work, because I visited the Hospital Albert Schweitzer in 1979. The Berggrens had come and gone by that time and had moved to Harvard to teach in the School of Public Health. So they were not physically there, but I did have a chance to see this program in operation, and it transformed my career. And through that experience, since I was training and to become a surgeon in Portland, Maine, the Bergrens were living in Boston, only 2 hours away. And so I got to know the Bergrens. And through that relationship, I got to know John Wyan, which led to all of this that has happened since then, which I'm very grateful for. So we've been exposed to a lot about Cure Americas over the last 2.5 days. So I'm not going to really spend much time on this, but just to give you a sense of some of the early applications of our work there, with, you can see in the bottom left the fact that every house had a number, and the people who lived in these homes, they knew what their number was, and we had a family health folder system that was based on that number in the village. And again, to repeat, we were able to demonstrate a statistically significant decline in under 5 mortality in a relatively small population, because the under 5 mortality in the comparison area was 200 per 1,000 live births. That's 20% of children were dying before the age of 5, and we were able to reduce that level of mortality in our intervention area to 100. That was a 50% reduction, but we still had a long ways to go to get it below 100, but that's where we were at that time when we published this. And we achieved very high levels of coverage of basic child survival interventions that we know are effective in reducing mortality in children. And we've talked about our work in Montero, Bolivia. We heard Dardo Chavez and his lovely wife Meetma share some of their experience. This is documented and published in 2 different articles side by side in a journal called Preventive Medicine and Community Health. And we've shown this slide several times now of the long-term mortality impact of their work in a peri-urban area, again, of Bolivia. And I'd like to give a shout out again to our colleagues from Guatemala. We have just published in February of this year a journal supplement which outlines their application of CBIO plus. And when I say plus, I'm adding care groups and local birthing centers into this. This is a 10-article journal supplement which is available online free of charge. And we are also selling a hardbound copy of that, which costs money to produce. But through the website, you'll be able to buy one of these if you're interested for $25. We have several in the room here too you can purchase, but I highly recommend that. The articles in this journal supplement, I'll just quickly mention what they are. But we have an editorial by our guest editors for this that includes David Pyle, who spent his career working at John Snow and all over the world, and another professor named Will Story. They were the guest editors for our journal supplement. The first article introduces the project and the area where the project took place, which is in a very isolated, very difficult to reach mountainous area of Guatemala, where the roads are very few and far between, and where, as I think we heard Alma say, the staff had to walk hours to get to these communities. And so that was the environment. A lot of more than 80% of the births were taking place in the home. Many of the women are illiterate. They're very limited education. They spoke an indigenous language. This had been a place which had been called the Triangle of Death, and in the Guatemalan Civil War, there was enormous atrocities against these people, and they were very suspicious of outsiders. So you can imagine that this is a very challenging place to work. But because of Mario Valdez's leadership and his capacity to work with local people there and his long-term engagement in that area, the project has been able to achieve amazing things. And so the second article describes the study site and the design of the research. The third article demonstrates amazing improvements in coverage of key child survival interventions based on household surveys. The fourth article is focused specifically on the results in improving the nutrition of under 5 children. So Guatemala has one of the highest rates of stunting in the world, and they have had very, very poor success in changing this. And millions of dollars have gone in, particularly from USAID and massive programs to make a difference, and they haven't shown any effectiveness. And so our project has shown a dramatic reduction in stunting within our project area of 100,000 people. Then the fifth article is an assessment of mortality, looking at all the various factors that affect mortality and the achievements that we had in reducing under 5 mortality, and also our achievements in reducing maternal mortality. And then we have an article about the Casas Maternas, the birthing centers. And then we have 2 articles that demonstrate the effectiveness of this program in empowering women. So I think this is terribly important. We've heard about the empowering effects of care groups, and we've seen that. But it's not only the care group volunteers who are empowered, but we have data that shows that women throughout the area, just the mothers and households, have been empowered by this project. Then we have an article that talks about key stakeholder perspectives on strengthening CBIO, and the last article is a summary with measurements of cost effectiveness and policy implications. So this gives you a sense of the area. You can see in the slide to the left where the project was located, in a very isolated corner of Guatemala, right on the border with Mexico. And these are indigenous Maya people who are still mostly speaking their traditional language. So these are some of the improvements specifically stated that I won't read now, but you can certainly read them yourself. And this is a slide that shows in the solid line the decline in stunting among under 2 children in our project area compared with the long-term lack of change in nutritional status that was measured by the demographic and health surveys in Guatemala. And our decline in under 5 mortality is measured by LIST. And as a matter of fact, I forgot to mention LIST when we were talking about mortality assessments. And I won't take time to go into it, but just to simply say right now that LIST is a tool that can be used to estimate under 5 mortality change that's based on improvements in the population coverage of interventions that have been scientifically demonstrated to reduce mortality. So it doesn't involve the direct measurement of mortality, but it estimates mortality change based on improvements of coverage of these interventions within a defined population of people. And it's a tool that is readily accessible online and so forth. We had a wonderful project in Liberia that we were able to get a child survival grant for with the Ganta Memorial Methodist Hospital that had amazing results. And again, using the care group approach with CBIO, these are some of the achievements that this project documented as a result of household surveys that were carried out at the baseline and at the end line of the project. I think these are quite dramatic achievements that our project was able to produce. And in fact, in that project, the vital events registration never really got going. And so the external evaluator at the final evaluation estimated how many lives were saved using LIST, the Lives Saved 2. And in a population of 140,000 people, which is the service area of our project, they estimated that 3,053 lives were saved as a result of our project, based on indirect estimates from coverage of childhood interventions, child survival interventions. Here are a few slides from our KeyCop project that we've been hearing about, and our friends from KeyCop, Ann and Kevin, are here with us today. And Kevin and Ann have mentioned this, but these are some of the findings that they have shared with us. They're based on small numbers. So you see here, there were 10 maternal deaths, and then it declined to 2 and then to 1 in their program area. But they're quite dramatic. And, you know, you can calculate a maternal mortality ratio with small numbers, but the statisticians and the scientists would say that's not appropriate, because the confidence interval for this, for such small numbers, makes it not a reliable estimate. But still, I think it's important to show that the numbers of deaths, in fact, has declined, even though it's not a large number of deaths. And this is the decline in the number of infant deaths. Again, small numbers, but much larger numbers than we had for maternal deaths. And then the care group projects, we've been talking about them. So I mentioned this before, but I'll go back and repeat it again. How with the care group methodology, you can have a very rapid expansion of key child survival interventions. And I showed this before, the rapid uptake of hand washing practices that are so important in preventing diarrhea in children, and the rapid expansion in immunization coverage, which the care group project helped to bring about in this particular project in Cambodia that I evaluated a number of years ago. And again, these statistics are based on, at the beginning and end of the project, a cluster sample household survey, but the other ones, intermediate, are based on mini MINI KPC surveys that I've talked about before. So I hope you remember when I mentioned that, how that took place. And this is, and I showed this before also, but it shows the dramatic decline in under 5 mortality that was measured by the care group members themselves when they met with their care group. They reported the numbers of deaths that took place, and then the promoter facilitator who was organizing their care group, she reported that up to the system. And this is what it turned out to be over a period of several years. And when I went out to evaluate this project, they hadn't consolidated this data yet. So I pulled it together and showed them what they had done, and they didn't even know it. But they had it readily available, and it only took me a couple hours to sort of bring this all together. Tom Davis spoke with us yesterday, and he's been a great advocate for care groups. This is an article that I was fortunate to help produce, in which a whole series of care group projects were compared with other USAID child survival projects that did not use care groups, and we're able to consolidate all this data and using, again, the list methodology, we were able to demonstrate that the care group approach produced a decline of under 5 mortality that was estimated to be 32% as compared to 11% among the projects that did not use care groups. So this is one of the reasons why care groups expanded so quickly. So Tina Jones was asking which projects are these. So Cure Americas was a part of, excuse me, a child survival and health grants program. And many of our projects were funded in large part by this grants program. But the USAID Child Survival and Health Grants Program funded many NGOs that did many different child survival projects around the world. And as the success of the care group approach was becoming demonstrated, there were more NGOs that started using this methodology who had received funding from the USAID Agency for International Development funding mechanism. And those projects all had a similar evaluation that was based on the changes in coverage of key child survival interventions from the baseline to the end line. So there was a uniform way of measuring the effectiveness of these programs, and using LIST, the Live Save tool, you can estimate what the mortality decline was. So that was all consolidated into this article. These were all of the USAID child survival projects funded through this program, and they were divided into two groups, the ones that used care groups and the ones that didn't, and we consolidated all this and published it. This is the article that describes the effectiveness of the project that Tom Davis led and I evaluated, that we published. It reached 1.1 million people. And we could have published 4 or 5 articles based on the findings of this, but we were only able to get one of these published that focused on the reduction in undernutrition of children. But you can see here that we calculated the average annual rate of decline in undernutrition, which is weight for age. We didn't have height data for this, unfortunately, but weight for age. And we were able to demonstrate that in the project area over a 5-year period, the average annual decline in undernutrition was 2.2% compared to nationwide data, which demonstrated a similar, which demonstrated a decline in undernutrition that was 5 times less rapid than what we were able to achieve with the Care Group project in Mozambique and 1.1 million children. So, in conclusion, CBIO principles have been used effectively in many different settings around the world. CBIO provides the opportunity to identify new epidemiological priorities as well as to design and test new interventions for addressing these priorities. So, as epidemiological priorities change over time, CBIO provides the opportunity to refocus the program on new epidemiological priorities that are coming forth. And I showed you the great example from Montero where they started out with an under 5 mortality rate. The first documentation we have of it was, I think, 130 back in 1992, but they've been working there and it was something like 150 or 180, although it wasn't shown on the graph, and now it's 6. So hypertension is now the epidemiological priority in Montero. It's not maternal and child health. So we're running way behind schedule. And so let me, if you don't mind, we're going to have time to talk here in a few minutes, but let me share another PowerPoint with you that was developed by Ira Stolick. You've seen Ira on the video yesterday or Monday.
Is it a video or a PowerPoint?
It's a PowerPoint. Hang on a minute. Let's see. Let me get it. Where am I? That's it. So Ira Stolick, who unfortunately could not be here with us because of family commitments, he's a long-term employee of our organization. He's now officially retired, but he's still helping us out a little bit. But he has done an amazing job in helping our program strengthen their CBIO methodology and the implementation aspect of the work. And he is passionate about CBIO and the value of it. And so he developed this PowerPoint, which I really like a lot, which unfortunately he's not here to narrate, but I'll just run through it quickly. And it's an advertisement for CBIO, but it is a repetition of many of the themes that we've already been talking about. So I'll just kind of run through this relatively quickly here. And in fact, I'm not going to really say much because you can read this more quickly than I can say it. Repetition is the secret to learning. So I'm building on that principle here. Everyone counts and everyone is counted, I think is an important theme that the Berggrens started promoting at Save the Children many years ago. Oh, too fast? Okay. And I guess the translators are going crazy, right? Maybe I'll slow down a little bit. Maybe I'll look to my translators. Give me a cue when it's time to go to the next slide.
Julia King. If someone could perhaps read the slides aloud as we go through, I don't know what you think about that, but discuss them all for consideration.
Okay, our translators are reading each word into Spanish and French, so a request has come from me to read this as well. So from the next slide forward, I'll read every word on here if that helps. So demonstrating actual impact. While all projects utilize methods of monitoring and evaluation to demonstrate changes in coverage of health services, they rarely can show that they have actually reduced mortality. CBIO is unique in that it can demonstrate actual impact on maternal and child mortality. We can show we really made a difference. The care group, mother, peer educators act as our eyes and ears and report to us all vital events, births, new pregnancies, and deaths among the families they serve. Thus, we can immediately respond with antenatal care or postpartum care and find out the exact cause of death. And here you see a picture of a death registry. Knowing the number of live births and deaths enables us to compute the actual maternal and child mortality and show year-to-year changes. And here you can see in the graph the decline in maternal mortality in our intervention area. And you can see in this graph what I have been talking about earlier, in which we show as vital events registration improves. Unfortunately, the graph shows an increase in mortality, but we know that we are confident that in fact that wasn't taking place. It just represents a more complete registration of the deaths that are taking place. But then you see a very strong decline. So for every death, we do a verbal autopsy with the family to determine the actual cause of death. Thus, we can show the actual local causes of death, and as already mentioned, we can target our interventions to precisely address local needs. In Guatemala, we were able to show that our interventions, especially our Casas Maternas, reduced maternal mortality 58%, from 524 to 221. Okay. Pat, you had a question? Okay, so Pat Taylor wants to know what the maternal mortality looks like today, and we lost our expert here. Mario, where did he go? Okay, so Mario Valdez will be the person to answer that. So when he comes back, we'll ask him to respond to that. So CBIO can be a vital complement to efforts to strengthen the services provided at health facilities, fostering a partnership between clinics and hospitals in the communities they serve. CBIO and care groups stimulate demand for health facility services to ensure that the facilities are actually used when needed. CBIO and care groups also catalyze behavior change that prevents disease, such as proper hand washing and childhood immunizations, to reduce the disease burden that health facilities with limited resources must treat. And here you have a photograph of mothers bringing children to a health clinic for growth monitoring. So, this says at the bottom, in Guatemala, we reduced maternal mortality by 58%. And in Liberia, we reduced under 5 mortality by 63% based on the estimates produced by the LIST tool, the LiveSave tool. In Liberia, the cost per beneficiary per year was only $7. In Guatemala, it was only $12. These are highly cost-effective interventions if you use current standards for assessing cost effectiveness. And you can see the improvements in coverage that we were able to achieve in our project in Liberia, and also at our project in Huehuetenango, Guatemala. So in conclusion, CBIO provides demonstrable, sustainable, and cost-effective impact. CBIO efficiently ensures that services are provided to those most in need in response to the actual local health priorities. CBIO ensures maximum bang for the buck through precision targeting of services and commodities. CBIO sustains its achievements by empowering communities and women to improve their own health. CBIO can demonstrate the actual impacts it is having on maternal and child mortality. For programs that seek to dig in for the long haul and create just and lasting change, CBIO can achieve sustainable, demonstrable, and cost-effective impact. Okay. Well, actually, we're not doing too bad on time. We've got, according to our previously developed schedule, at 11 o'clock, we're supposed to begin a wrap-up discussion and closure of our workshop. So let's take a couple of minutes here as we transition. But Mario Valdez has come back in the room. So while you were out, the question was asked. We showed this slide, actually. Can you go back to that slide or help me get back into that, Andrew? Yeah. Yeah. Sorry about that. Right here, yeah. Complicated. Okay, Mario. So I'm very happy here to share the podium with Mario Valdez, who has been directing our work in Guatemala for 22 years now, and is a passionate advocate for improving maternal, neonatal, and child mortality. And so, Mario, while you were out of the room when I was sharing this slide, Pat Taylor asked the question, what is the current status of maternal mortality in our programs in Guatemala? Because this graph stops in 2014 and 2015. So what can you share with us about what's happened in the last 8 years or so in terms of maternal mortality?
Sí, bueno, concretamente ahorita no tengo los datos, pero se puede visitar las salas situacionales del Ministerio de Salud. Ellos tienen ahí los informes, incluso está hasta mayo del 2023, pero lo que hemos identificado y que ayer también el doctor Rodríguez decía del área de salud de San Marcos, es que esas intervenciones de las casas maternas han disminuido bastante la mortalidad de estas áreas. En Huehuetenango se ha notado también que año con año va disminuyendo. También han tenido otras intervenciones porque en Huehuetenango llevan ya 3 cortes de parteras y esto se ha distribuido a los municipios que tienen mayor mortalidad. Entonces, como decíamos, yo creo que esta estrategia en forma conjunta es demostrable. Y Kevin también ayer decía que esto también se puede utilizar no solo en Guatemala, sino en muchos países del mundo para poder reducir drásticamente la muerte materna.
Okay, thank you. Thank you, Mario. So we're going to take a 2 or 3 minute break here, and then we'll reconvene for our last session. Thank you very much. Okay, I think we should reconvene here. So if you can take your seats, reconnect, get yourselves going. Am I coming through on the system now?
Yes, you sound good.
Okay, good. So we've got about 45 minutes left. And so what I want to do is go through this PowerPoint I have relatively quickly. And then I want to leave a little bit of time for any comments that any of y'all would like to make as a final wrap up. So what I wanted to share during this final wrap up session is looking to the future and the relevance of CBIO and why I think CBIO has a bright future and building a vision for the future. My computer doesn't want to cooperate. Oh, there it is. Okay. So my first point is that I think it's possible for communities and local field staff to develop the competencies that are required to implement CBIO. That's a fairly strong statement, but a lot of the techniques and tools were originally developed for field research by university level people and highly qualified technical people. But I think we're entering a point in time where we need to learn how to enable people at much lower levels, even down to the community level, to be able to use these tools and techniques which are necessary to make CBIO work. And BRAC is a great example of what can be achieved with a system in which you have strong training programs and strong supervision carried to scale. And if BRAC can do it, other programs can do it too. And I've mentioned before that I know that knowledge, practice, and coverage surveys can be carried out by local groups, and our group from Guatemala is a great example of how local people were trained to do household surveys that we believe were very high quality. And all the steps of it, the design, the sampling, the training of interviewers, the collection of the data, the putting the data in the computer, and the analysis of the data and the write-up of the data, they were all able to do. And if our staff in Guatemala can do it with very low-level staff, then other groups can do it too. And again, our Guatemala team has demonstrated that these same people, these same local field staff, can register vital events and can put them into a database and can analyze them and produce mortality rates that we think are relatively accurate. They may not be perfect, but we think they're relatively accurate. I spent 10 years working on what is a book that you see here, but it was also published as 11 different articles in one of the peer-reviewed journals that's important in global health. And the woman who directs the community health work at USAID has told me repeatedly that this book changed the course of USAID priorities, United States Agency for International Development's priorities for their programs around the world. And so the reason I say this is that evidence matters, and people are paying attention to it, whether you realize it or not. And when policies are made and when programs are developed, people want to know what the evidence is. And as a matter of fact, just today, when I was looking through my emails this morning, I found an article that was just published this month on measuring maternal mortality in underserved areas around the world that cited our work from Guatemala that was published in February. So this was just one example, and this was some group in the Netherlands, I think, that was publishing this, but people are looking for this. And if there's evidence that is convincing, people are going to make use of it. And that's one of the values of documenting what we're doing in these early pioneering projects. I mentioned this before on the first day, but again, remembering the principle that repetition is the secret to learning. I want to repeat this slide because I think it's a very powerful slide, but it's based on the Lives Saved tool. And it's kind of complicated in a way, but it's very simple in another way. But if you assume that everybody who needs hospital care was able to get it and receive the services that a hospital can provide, and if you assume that everybody who needed care at a primary health care center and the services that can be provided there receive them, and if you assume that people who could, if you assume that the interventions that community health workers can provide in the home, in the community, if 100% of the people receive them, and if you look at the effectiveness of these interventions, it's been proven through repeated studies around the world, you can estimate from LIST, the Lives Saved tool, the number of lives that would be saved if we had an ideal world in which everybody got these interventions. And so what this analysis shows is that if every mother and child received the interventions that we know work, then it would save 2.4 million lives each year around the world. This is home-based neonatal care I'm talking about. It's the community case management of pneumonia I'm talking about, basic nutrition interventions. Immunizations, yes, but one of the interesting things about immunizations is because the coverage of immunizations is relatively high, the additional number of lives saved by expanding immunizations is not as great as it would be as if you expanded home-based neonatal care where the baseline coverage is already very low. But immunizations are important, and that's a community-based intervention that can be provided in the community. And if you look at the number of lives that would be saved at the primary healthcare center level and at the hospital level, that adds up to 1.7 million as opposed to 2.4 million in the community. I don't have the data to show this, but I would be willing to bet that 90% of the money that's invested in a health system either goes to the hospital or to the primary healthcare center. And 10% of the money is going to community outreach. And that's, to me, a huge issue in global health. And this is government money I'm talking about. The donor money is relatively small in terms of what it costs to run these programs. And so it's the government's investments that are so important, and the great need we have to somehow motivate governments to realize the importance of these community-based interventions. But as I've said before, there's enormous pushback against that because it means less funding for hospitals. It means less money for primary healthcare centers. It means doctors going on strike. I mean, all kinds of things. So it's a very complicated picture, but it's still something we have to keep pushing forward. And as I mentioned before, there's a very exciting opportunities for community-based primary healthcare to make a real contribution to the mitigation of non-communicable diseases, and hypertension is the quintessential example of what will be able to be done in the future by a community health worker going from home to home, taking a blood pressure like you saw them doing in Bangladesh, identifying adults with asymptomatic high blood pressure, because high blood pressure is an asymptomatic condition. They don't know they have it. Identifying people with high blood pressure and then getting them into treatment, but at home without having to go to a facility. And this can be done through a protocol that's supervised by higher level physicians, that's based on scientific evidence. I've been a part of a pioneering study in Nepal that's actually doing that right now. So and in fact, hypertension is the leading preventable cause of death and disability in the world today. And so it's maternal and child health issues, as important as they are, if you look at it in the big picture, they're diminishing in their importance. And these chronic diseases are moving very rapidly into epidemiological priorities. And so the potential of home-based care to address these issues is one of the exciting opportunities of CBIO, and BRAC is a great example of an organization that has moved into and embraced the use of their community health workers to address these issues. And in fact, mental health is another one. And I didn't have time to get into this, but BRAC now has a program in which their community health workers identify women with postpartum depression. That's becoming an important issue. And so they have a system in which the community health worker identifies women with postpartum depression, and then they have a group of women who have been trained to counsel women with postpartum depression, and they go to the home of that mother and give her counseling. It's another example of what's moving forth in terms of the potential of community-based primary health care for addressing non-communicable diseases. I was a part of the core group polio project, which is a massive funded effort from USAID to contribute to the eradication of polio. And the core group, which is an association of NGOs, received money to work in the very most difficult places where polio was not being eradicated. And so we have a journal supplement that I helped to guide that documents over a 20-year period the success of the core group polio project. And it all boils down to reaching every household with community level workers, and also promoting the uptake in every household of repeated polio immunization, but also routine immunizations as well, through a census-based approach, where they did this in the most difficult parts of India and Ethiopia and a number of other countries where polio eradication was lagging behind. And it's been attributed to be the key factor for India's ability to eradicate polio early on in the process, which many people thought would never be achieved. So, what are some of the drivers to bring primary health care and also CBIO principles into the mainstream? I've already mentioned these, but I think these are very important to remember as we think towards the future. One of the things that I think about a lot is how we can make CBIO more widely applicable, but I've come to the conclusion that it's much better to keep CBIO as a set of principles, but not make it too rigid in terms of exactly how to do it, because the local contexts are so variable and the local resources are so variable. So promoting a methodology that is very strong on principles, but which leaves to each group that's applying it the flexibility and the creativity to adapt those principles to the local circumstance, I think is an important principle. And I've thought about this over the years, and I thought about it again, and I was thinking about how to conclude this workshop. And so I used to be a general surgeon, and so I've had a lot of exposure to surgery, and I was a surgical resident about the time that heart surgery was moving into the mainstream. And if you think about the initial pioneers who developed the techniques for open heart surgery, they were an extraordinary group of people. And it took extraordinary courage and creativity and passion to perform the first open heart procedures, whether we're talking about valve replacement or coronary artery bypass grafting. But now it's become one of the most common surgical procedures in the world. And so obviously it takes special training. It's not short-term training, but there are steps that you have to go through and procedures you have to follow to learn how to do this stuff. Not only on the part of the surgeon, but on the part of the hospital that's performing this. And so if the world has been able to scale up heart surgery so that it's now one of the most common surgical procedures in the world, I think that we can do more in terms of developing the application of the principles of CBIO so that the more widely available, because of the power it has to save lives. This is Carl Taylor. I've mentioned him a number of times and was a close friend of John Wyans. Just before he died, he was working on an article that we were able to get published in the Lancet. And this is the key phrase from his article, which I don't have time to tell you more about right now, but I was involved in the wording for this. We put a lot of time into this, and it was what Carl was trying to say, but we tried to get the words just right. And so I think there's a powerful message here which applies to the approach that we're promoting here in this workshop. I have always found this statement to be a very powerful one. I've been focusing on this for a number of decades now when I first read it back in the 1980s. But when I read this statement, I ask myself, of course, Rex Fendall, who was a British physician who worked in Africa many years, who was a pioneer of using auxiliaries to do basic health care. He was writing this in 1972 and looking towards the end of the 20th century. So now here we are in the year 2023. And when we get to the end of this century, we're going to be asking the same question as he asked for the 20th century. I think it's an important issue. So I wanted to share with you one of my all-time favorites. This is a 3-minute video, and it's not precisely focused on CBIO, but a lot of the ideas in it are highly relevant to what we're doing and promoting with CBIO. This video is 3 minutes long, so don't expect some long drawn out thing.
Imagine a health worker.
It's simple, isn't it?
Isn't it?
Let's imagine she's...
Or she's...
Imagine she's a he.
Let's stick with a her. What about we call her Flo?
Florence.
Flo.
The thing is, whatever a health worker looks like, whatever she's called, imagine this. She saves lives every single day.
She's amazing.
But like many of us, she dreams of more.
Imagine that dream takes her to the big city.
You don't have to imagine that. This is what happens, time and time again. She might get a job at a private clinic. Or maybe she moves abroad to chase her dream.
Look, here she is in London.
She's working in a hospital.
Now imagine what's happened to us.
The people she left behind.
My wife died when she gave birth with no health worker to help her. Nobody in our village gets vaccinated.
Our children are dying from pneumonia and diarrhea.
We don't know how to protect ourselves from HIV and malaria. It would only take one health worker to show us. There are 2,000 people in our community, yet we don't have a single health worker.
Where's
the health worker? Where is she?
It's hard to imagine 1 billion people.
It's harder still to imagine 1 billion people without a health worker.
Okay, cheer up. Imagine this.
Imagine she stays. What would it take to make her stay?
Imagine investing in her. Imagine paying her a living wage.
Imagine giving her quality training that she can pass on. And imagine giving her the proper tools for the job.
Now she's got support.
She feels safe. she's also got the respect of the people around her.
We listen to her and we learn.
She is important to us and we value her.
Imagine what would happen then.
Over the years, she could save hundreds of lives.
She could inspire and train hundreds of others to become health workers like her.
I could be one of them.
So could I.
Each of us could be saving lives in our own communities.
Imagine that.
And then imagine what happens next. And then?
And then? A health worker for everyone, everywhere. Imagine that.
Now,
Okay, can you hear me now? This is a little bit of a complicated slide, but I put it up here so that you can see, get a glimpse of what is, I consider, an amazing chain of events of influence that have promoted community-based primary health care and CBIO principles, even though they didn't call it CBIO. And it goes back to, and of course, I don't have time to explain everything that's in here, but you can see that Carl Taylor, who is kind of in the center, right in the center of the slide, has had a powerful influence on John Wyan, who has had a powerful influence on us and the Bergrens. And the Bergrens have had a major influence on child survival programming throughout the world. Carl Taylor had a major influence on the Naringwal project in India, which had a major influence on the JomKed project in India, the search program in India, the search program in India, that's a mistake, that shouldn't say Bangladesh, and the MATLAB program in Bangladesh, which had a major influence on developing BRACS programs, all through home visitation from female community health worker programs, and how that led to the influence nationally in Bangladesh and even into Ghana. And I don't have time to explain all this, but we're part of a small but very highly influential network that is expanding this idea forward. And it's going to continue. I don't have any doubt about that because it's so powerful, but it's been very slow in getting going. So it's now 11:37, I think, according to my watch. So I still firmly believe that it's people and not money that are our greatest resource in global health, and how we can work with local people to help them improve their health is the great frontier for improving the health of people around the world today. It's not the money that the Gates Foundation is going to give or the World Bank, but it's the opportunity that we have to learn how to work with local people to help them improve their health. So community and people are resources, they're not just targets. So too often over my entire lifetime, we've considered communities as a passive recipient of service, as a target, but we need to learn how to make them resources and partners in driving these very simple interventions that save lives. And we need to start small. And there's so many examples around the world where small projects have led to big things. There are many examples around the world where small projects were great, but they failed. They didn't scale up. But still, we have enough experience to show that it is possible for successful small projects to scale up because of their effectiveness, but it takes time to do that. So I would like to, I'd like to take about 15 minutes if we could, so that if any of you would like to provide any concluding comments. I don't think we want to get into questions now. We've had plenty of chance for questions. But if any of you would like to share some comments about important insights that you gained from this, or something that you'd like other people to hear who are a part of our workshop, this will be the time to do it. So if you'd like to make a comment and you're online, just unmute yourself and speak. And also, if we could see your face, if you could put yourself on video, that would be great too. Yeah. Can you fix the video so that they're seeing the Zoom participants? Okay, so we see Amsalu Shifra. Are you ready to say something, Amsalum? And if so, tell us who you are and where you're speaking from. Can you unmute yourself, please?
Thank you, Professor Henry. Can you hear me?
Yes, we can. So go right ahead. You're
okay. My name is Amsalu Shfarao. I'm from Ethiopia. Ethiopia has an experience on community health service, including the health extension program. And the last 3 days workshop has provided a lot of insights and experience across the world. And it is really very helpful, and it will, I hope it will contribute for that. As you have mentioned, the future is the era of community health, because unless community health system is strengthened and improved, achieving universal health coverages will be in orders, not in practices. And I gain a lot of experience here, and thank you for the organization and an opportunity as well. Over to you.
That. Thank you very much. I saw Stanley Blanco's face appear here. So Stanley, were you going to want to share something with us? If so, please go right ahead. We can see you now very well. And so please share what you'd like to. Stanley Blanco is a Bolivian who's been connected to our work in a peripheral kind of a way for many years now, and is one of the great leaders of public health in Bolivia. Stanley?
Well, good morning to all of you. My name is Stanley Blanco. I am working in Bolivia now, and these 3 days were just amazing, because we were able to remember how public health has been developed on the Altiplano. The Altiplano area in Bolivia is with Aymara people living over 4,000 meters above sea level with their specific characteristics. And what is important for me, and what is important for public health in this case, is that CBIO was the beginning of what Bolivia is going through now in the health system. Right now, we are going towards the universal health coverage. And for us, the models of Ancoraimes, Carabuco, El Alto, and Montero were used as, if you remember, when Dr. Trujillo explained, he was very proud of having used CBIO to scale up the program, the process, and to include into public health and universal health coverage. I want to thank you for letting me participate in this, and les mando un gran saludo a todos los amigos de Guatemala, de Kenia, y muchas gracias por permitirme estas palabras.
Thank you so much, Stanley. We appreciate those kind words. We have several hands raised up now, so I guess I will call on one of you so each of you don't try to speak at the same time. So the only name I see at the moment is Arwal. So Arwal, I'll recognize you first. And then there's another person who doesn't have a name who has their hand raised. So whoever that is, after Arwal speaks, then we'll let you speak. So Arwal, please go ahead.
Thank you so much, Dr. Hani Piri, my Ustad, and you are my teacher, and you are inspiring us all the time. And thank you so much for after this conflict situation in my country, you give us chance to refresh our knowledge and know about the useful activity of the community-based healthcare or community-based initiative in the world. So, and in the same time, I was so happy that it was refreshed for me that what I saw and I learned from different projects of the India and Bangladesh and at the same time for us, mostly you say some example of Dr. Carl Taylor. Taylor was my professor too, and as he was my friend. And the last year of his life, I was for around 1 week in his home in Baltimore. We were together, and all the night we were talking about the community engagement, community importance in the world, especially in Afghanistan, and for improving of the health service. And now I learned more about the community-based healthcare activities from this approach of CBIO, and this was very interesting for me. I learned more about that. And even there was some difference, but the same things, the same activities in purpose we are using in Afghanistan by the name of CBC, our community-based primary healthcare programs in our countries. And this was very interesting, and I hear from different colleagues from different countries in different areas, their experience in their projects. We hear about from them more interesting impact of this approach. So really, it was very interesting for me at this time, this training and this learning from you people in exchange of the knowledge between the colleagues. So it was my pleasure to be with you in this training program, and hopefully to in the future at least what my experience and what I learned before from you peoples to use for improving of the health of the peoples. Because if we are not working for the main partners of the all projects in the world, that is the community or beneficiaries, if we not engage them, if we not empower them, the community will not feel the ownership of the projects. And that's very important for successful program when the community or beneficiaries got or feel the ownerships of the program. So this is the best tools for the feeling of ownership by the communities and involvement of the communities. As Abiban says that we have to do for the people, by the people, with the peoples. That's very important. And we learned that. And thank you so much, Dr. Hani Piri, that you give us chance to once again learn from you and from the colleagues from different area. That is all for me for this time. Thank you so much, and over.
So we have heard from Saeed Abib Adawal multiple times during the course of this workshop, which has been a real inspiration. Arwal has been the champion for community-based healthcare in Afghanistan for more than 2 decades now. And he's been slogging away, obviously with a lot of external support, but at the same time, he's been the our Afghanistani champion of community health that has led to extraordinary progress in improving the health of the people of Afghanistan. And he hasn't quit yet, even though he's now at Harvard and is holding forth from there. But we'll be hearing more from Arwal over the years as well. So Arwal, we are so grateful for your commitment and dedication and the progress that you made in bringing community-based healthcare into the mainstream of the Ministry of Health's work in Afghanistan for a very large population of people. Thank you.
Yeah, thank you so much.
I now see my dear friend Wes Jones on our screen here. Wes, are you going to make a comment?
Yes, thank you. 2 points. There's an old saying, united we stand, divided we fall in the United States. And we have a number of different projects here today. And Cure Americas has found the value of linking their programs in Bolivia, Guatemala, Liberia, Haiti online. I'm not sure how often they're meeting. I think it's every 3 months or so. And they've found this highly educational. I would encourage the people here today to talk together on a periodic basis. You'll learn from each other the challenges that you face. And Andrew has mentioned that the programs in the different countries are now demanding that they meet. They found it to be so much value. That's the first point. I'm struggling to remember the second point. The second point is that Guatemala got started visiting the program in Bolivia. And this has been mentioned as helpful to visit other programs, but I want to point out that Haiti and Kenya programs before getting started visited the project in Guatemala. I just cannot begin to emphasize the importance of this. So if you have someone visiting your program, you might also encourage them to visit another project to get a better conceptualization. As Henry stressed, flexibility with CBIO is critical because each program and each community is different. So flexibility is huge, but keep focus on the importance of communication and any early programs. And if somebody's inquiring about it, encourage them to visit other projects to get a better vision of it. Thank you.
Can you hear me? Wes, thank you so much. Wes Jones is Cure Americas' dearest friend, benefactor, cheerleader. He's been involved with our organization for almost 40 years now, has been to all of our program sites multiple times. He's been the chair of our board for multiple occasions, and he is now our cheerleader to help us raise an endowment to provide long-term support for our work. He's a retired gastroenterologist who lives in Fayetteville, North Carolina, but he went down to Montero in the mid-'80s and has been hooked ever since. So Wes, we love you and thank you for all that you've done to help make this work move forward. There's somebody who I can see only as iPhone with their hand raised, and that's the only hand raised I see. So whoever you are, unmute yourself and hold forth if you would.
Thank you very much,
Is that the only hand
Dr.
raised?
Perry, for this opportunity. My name is Dr. Kokua Una Williams. Can you hear me?
Yes, tell us again who you are and where you're speaking from.
Can you hear me?
Yes, better.
Oh, Dr. Harry, my name is Dr. Koku Uno Williams from Ghana, and just want to thank you for the opportunity to participate in this program. It's been a very 3 days well organized and very enlightening workshop. In Ghana, we also have done some work on community-based health systems. And I think some of the examples from BRAC feed into our work. So what you have taught us is just to reaffirm and confirm the belief that, you know, community health systems improves and saves lives. From Ghana, we are very grateful for the opportunity, and we hope that we will collaborate again in the future, in future workshops. Thank you very much for the opportunity, and thank you all for the colleagues and the participants and all the people who give us these wonderful tutorials. Thank you very much.
Thank you so much. It's great to receive that comment. And if you probably didn't notice, but the slide that I showed with all the interacting influences to start with Carl Taylor, we had Ghana in there, the Navrango program in Ghana, which was the beginning of the community health strong program in Ghana, was directly related to the MATLAB ICDDRB program from Bangladesh, because Jim Phillips, who was the real force behind carrying this work to Ghana, worked for many years in Bangladesh at the MATLAB Maternal and Child Health Program. So it's just another example of how the influence of various personalities and friendships and belief in the power of this is spread from one place to another. So I don't think we have any other people who have raised their hand.
We just have comments saying thank you from Haiti.
Okay, so we have a number of comments in the chat box that you can see, thanking us for the workshop. So we're grateful for that.
We also have somebody, Samuel, who's saying I'm here to join the group of CBIO champions.
So Samuel, I guess we heard from him earlier, said that he's here to join the group of CBIO champions, which is great. So let me can you get my PowerPoint? Yeah, so we have one other person who wants to make a comment. This is Tina Jones, who is the former chair of our board of Cure Americas, who is a lawyer in Raleigh, North Carolina, not a health professional, but she's done a lot of work in the health field as a lawyer.
Thank you, Henry. Thank you for indulging me. Like you said, I'm not a healthcare worker. I'm not medically trained, but I do have a passion for this work and have appreciated the opportunity to spend time and do what I can to help promote Cure America's work over the years. I just wanted to add a couple of quick comments from the perspective of someone who is trying to support this work as a board member, as a former chair of the board of directors, and someone who's not doing the actual work, the very important work with our communities. Wani, something that Wani said earlier struck me, because she said it's hard to establish trust in a virtual world. And it's great that we have the ability to communicate with one another and to participate virtually. But there's nothing like being here in person. And following up on what Wes Jones said earlier about it being a strategic priority for Cure Americas to put in the effort to share knowledge among our projects in different parts of the world, and for Guatemala to sort of stand on the shoulders of Bolivia, and then Kenya and Haiti to stand on the shoulders of both Guatemala and Bolivia. That has been a strategic priority for Cure Americas. I think Henry said in his comments earlier that theory can be way different from actual practice. And there's another element, and that is strategic planning versus what actually happens in implementation. And so I would just encourage us to not only continue collaborating on the things that are happening to serve our communities via the actual healthcare that is being implemented, but also to collaborate on goal setting and strategic planning amongst our project sites and amongst various organizations. When we were talking about what can we do to promote CBIO, I think that's what we can do. I mean, all of us have to do things like communicate with our government officials, develop relationships, go through different election cycles and developing those relationships over time and with new government leaders that are coming in, creating strategic plans, creating goals for 5 years and 10 years out, and creating contracts among partners. All of those things are not the ultimate work that we're wanting to get done, but it's all important because you need funding, you need cooperation, you need leadership, you need relationship building. And so I just wanted to add that other little piece, and that is, let's continue to coordinate, let's continue to visit each other, let's continue to get together to continue establishing that trust that Wani was talking about, so that we can develop goals and strategies for continuing this work well into the future. Thank you for the opportunity, Henry.
Thank you, Tina. Thank you very much. I want to bring the PowerPoint up. Yep. It's now 12:01 according to my watch. We're not quite finished, but we're very close. So once again, I want to say a special word of thanks to the various people and organizations that made this possible. This has been a real teamwork effort. I'd like to give a special shout out to Wes Jones. You just saw him a minute ago, but he made it possible for us to have translators into Spanish and French. And all of this is being recorded, as you know, and it will be on our new website to promote CBIO. So we've invested in this to make this experience available to many other people. We've had an amazing team of people behind the scenes that have helped to make this possible. I've never done anything like this before, and this is a very complicated operation when you're talking about involving people from around the world as participants and having this online and on site at the same time. And our friends at the Christian Connections for International Health have done an amazing job. May Podjushink in particular, you've been getting emails from her, but she's been really amazing, and we're grateful to you, May, for all your help and support. Both Barbara Mufuletto and Andrew Herrera have been amazing support as we've moved back and forth through various media that are required to open up and close the PowerPoints and involve the bilingual groups and the PowerPoints and the videos, et cetera, et cetera. It was very complicated, and you may not realize this, but it was not easy. But I think, and of course, the first day we had a number of glitches that slowed us down, but we were able to overcome the challenges that we faced. And so we're grateful for the Duke Global Health Institute, which actually sponsored this institute that made it possible for us to use this facility here at Duke University, and we're grateful to them. I'm always grateful to my alma mater, where I've been on the faculty for many years at the Johns Hopkins Bloomberg School of Public Health. We're indebted to Cure Americas Global, as you can certainly tell from their active participation in this and from all the work that Cure Americas has been doing for 40 years. One of the reasons why our team is here is, most of you don't know this, but last Thursday night, Cure America celebrated its 40th birthday. And we had a major celebration at the Duke School of Nursing. And our colleagues from around the world came here primarily for that purpose, to be there for that special moment in the life of Cure Americas. And it prompted me to think what a great time this would be to have a workshop to talk about CBIO. So we're grateful for them to be here and to Cure Americas Global. And then finally, I want to give a shout out to an organization that is just now emerging, which is called CBIO Global Health Initiatives. And it's a small business that I'm running. We don't have any money right now, but we're going to use this as an opportunity to try to promote CBIO principles and experience with CBIO. And we have a website, as you know. And we heard from Michael Larby yesterday, who's a colleague of mine who's helping us develop this website. And we're hoping that through the website, we can create a community of learning and an opportunity for those of you who have joined us to continue to be engaged and to have access to resources and to be able to share principles and practice throughout the world as a mechanism for spreading CBIO. And so since we have your email addresses, since you registered for this workshop, you'll be hearing from us, and we look forward to hearing from you and creating this into an interactive community of learning that we hope will grow and expand over time as one of our dreams and aspirations. So we thank you for that. And it's now 12:06, and I think it's time to call an end to this. But we're grateful to all of you who have joined from around the world. We're grateful to those of you in this room here who have also come from around the world to be with us. And we hope that you will share this workshop with other people who might be interested, and you'll be able to link into this, and other people can link into this readily on our website, although it's still at the moment in process, but it'll be up and available in the near future. So thank you very much. It's been a great pleasure for me to help to make this workshop into a reality. Thank you.